Let's discuss airway obstruction. Here is everything you need to know about airway obstructions. An airway obstruction occurs when the normal flow of air into the lungs and into the airway is blocked or restricted, preventing adequate oxygenation. This can be partial, where the airway is only partially blocked, or complete, where it is completely blocked and no air can get through. A partial airway obstruction can be mildly serious to moderately serious. This is because in a partial airway obstruction, some air exchange is still present. In a partial airway obstruction, the patient may be coughing forcefully. They may have stridor or a high-pitched whistling noise coming from their upper airway. They may have gurgling sounds, which indicate fluid in the airway. If at any time you believe a patient is suffering from an airway obstruction, but the patient is still able to cough, breathe, make sound, or talk, then the obstruction is partial and not complete. In contrast, a complete airway obstruction is a severe airway obstruction where no air exchange occurs. The patient cannot speak, cough, or breathe. And the patient may present with the universal choking sign, where they put their hands around their neck. If you suspect that a patient has an airway obstruction and they are unable to speak or make sound, then they are suffering from a complete airway obstruction. Both partial and complete airway obstructions can be caused by many different things, including foreign bodies like food or small objects, swelling from allergic reactions like anaphylaxis, burns or infections, tongue obstructions like in unresponsive patients who can't control their airway, and that can lead to snoring respirations, trauma, where there's facial trauma, airway swelling, blood or secretions, laryngospasm, spasm of the vocal cords, and much more. The proper way to manage an airway obstruction depends on the cause of the airway obstruction and whether the obstruction is partial or complete. For example, if a patient has gurgling respirations, it indicates fluid in their airway. This would be known as a partial airway obstruction since the patient can still partially breathe. Hence the fact you can hear the gurgling respirations or air coming through the fluid. If gurgling respirations are present in a patient who cannot control their airway, you should suction their airway. If the patient is able to control their airway, then you should encourage them to try to cough out the fluid on their own. If a patient is vomiting, then you should lay them on their side if they're unable to control their airway but are still conscious. If they're unconscious, then you would suction the airway. Now let's cover what to do if a patient says they're choking or is presenting with the universal choking sign. If a patient presents with the universal choking sign but is talking, or in general is just saying they're choking, you should encourage them to try to cough up the object but should not perform any choking relief techniques. This includes avoiding slapping their back. This is because the patient is able to move air, and choking relief techniques will only work if the patient has a complete airway obstruction. Doing choking relief techniques on a patient who does not have a complete airway obstruction will not help and will only hurt the patient. So again, if a patient says they're choking or looks like they're choking, but is able to speak or make sound, then you should encourage them to try to cough up the object on their own. You should also wait with them and monitor them in case the obstruction becomes complete. Now let's talk about how to manage a complete airway obstruction. You should know that partial airway obstructions are not referred to as choking. Only complete airway obstructions are truly referred to as choking. The proper management of a complete airway obstruction depends on the patient's level of responsiveness and age. For a conscious and responsive adult or child with a complete airway obstruction, perform abdominal thrusts by standing behind the patient, placing a fist just above the navel, and delivering quick upward thrusts until the obstruction is relieved or the patient becomes unresponsive. If the patient becomes unresponsive, lower them to the ground safely and begin CPR immediately, starting with chest compressions and without doing a pulse check. Before delivering rescue breaths, check the mouth for visible objects and remove it carefully. If you do not see the object, do not stick your fingers in the airway or attempt to do a blind finger sweep. Blind finger sweeps are dangerous as they can push the foreign objects deeper into the airway and can result in trauma to the airway. Now let's talk about infants. For a responsive infant or a patient under the age of 1, administer back blows by striking between the shoulder blades followed by chest thrusts using 2 fingers at the center of the chest. You should perform 5 chest thrusts, then rotate the patient over and perform the 5 back slaps. You will repeat this process until the obstruction is relieved or the infant becomes unresponsive. Again, if the infant becomes unresponsive, begin CPR immediately without doing a pulse check. You might be asking yourself, why do we immediately start CPR if a choking victim becomes unresponsive, and why do we not do a pulse check? If a choking victim becomes unresponsive, CPR is started immediately because chest compressions can help dislodge the object while also maintaining circulation. In addition, patients who become unresponsive after choking are likely to progress into a state of cardiac arrest very quickly. Checking for a pulse is skipped since CPR will be performed even if a pulse was present. Want to watch the full video? Watch the full video and get so much more with your full access membership by going to howtonremt.com or scanning the on-screen QR code now.